and welcome to my channel. We have already discussed our general surgery subject and systemic surgery subject. We have covered all the units and all the important topics along with the scenarios and the clinical features, the important investigations and the treatment, the differential diagnosis, and other important points related to the topic. Now we are starting our medicine subject. We will prepare the short answer questions and MCQs for our professional exam. So we will start it from the CVS. We will divide the medicine subject broadly in two sections, that is medicine and medicine B. In medicine A, we will discuss the CVS, the pulmonology, the endocrinology, the rheumatology, the CNS and the psychiatry unit, and the rest of the units will be discussed in the medicine part B. So today we are starting the medicine part A, and the first unit that we will be discussing is CVS. So starting our video, the in CVS we will discuss the following topics, that is atrial fibrillation, supraventricular tachycardia, stable angina, congestive cardiac failure, myocardial infarction, rheumatic fever, mitral stenosis, aortic regurg, infective endocarditis, hypertrophic obstructive cardiomyopathy, pericarditis, constrictive pericarditis, core pulmonale, and deep venous thrombosis. We will discuss all these topics in this video. We will try to cover the unit CVS in two videos in two parts, and we will discuss each unit per day. So we will cover our medicine subject in a week. So starting from our first topic, that is atrial fibrillation. We are having a scenario that there is 60 years patient, that is female, with 2 months history of shortness of breath and clinical features of heart failure. She is found to have atrial fibrillation with uncontrolled ventricular response, that is 135 beats per minute. So what are the causes? Then mention 3 drugs to control ventricular response and what are the investigation options. So the causes of atrial fibrillation can be remembered from pyrites, that is for P is pulmonary embolism, I ischemic heart disease, R rheumatic fever, A atrial myxema, T thyrotoxicosis, E ethanol, S sepsis, and chronic atrial fibrillation is due to hypertension and congestive heart failure. Now what are the diagnoses that we will do for the case of atrial fibrillation? These are ECG. No P wave will be present. Regular but irregular QRX complexes, that is irregular RR interval is present. Then X-ray is done to exclude lung diseases. Echo is done to find the characteristic flow pattern. TFTs are done, that is thyroid function test, and H and history and physical examination are done for the case of atrial fibrillation. Now coming towards the symptoms of atrial fibrillation are palpitation, weakness and shortness of breath, stroke, ischemic heart failure, and atrial fibrillation induced cardiomyopathy. These are the complications. Atrial fibrillation can present with stroke, especially in young age. The signs are that pulse will be fast and irregular. Heart failure, that is sign of underlying, and diagnosis of, for example, mitral stenosis. On ECG, there will be no P wave. The risk factors are that CVS, high blood pressure, coronary artery disease, and valvular diseases. And the non-cardiac risk factors are obesity, diabetes, and excessive alcohol. These are the risk factors for the atrial fibrillation. Now, the drugs that used to control ventricular response are calcium channel blockers to stop ventricular response, then beta blockers to stop beta 1 activity at S anode. Digoxin is used for heart failure, arrhythmia, and abortion, and verapamil or dilatazam is used for hypertension and angina. Now, the management options for atrial fibrillation is broadly classified, that is for hemodynamically unstable patient and hemodynamically stable patient. For hemodynamically unstable patient, do immediate electrical cardioversion. For hemodynamically stable, the steps of treatment are that in step 1, control heart rate, that is give beta blocker, calcium channel blocker, and digoxin. Then in step 2, control heart rhythm, that is if atrial fibrillation is less than 48 hours and at low risk of stroke, using CHAD score, that is give intravenous heparin followed cardioversion. If atrial fibrillation is greater than 58 Hz and high risk of stroke using CHAT score, then the option 1 is that give anticoagulants for 3 weeks, then perform cardioversion. The option 2 is to avoid waiting 3 weeks for anticoagulation. Obtain transesophageal echocardiogram to look for atrial thrombus. If thrombus present, then follow option that is 3 weeks anticoagulation, cardioversion, and anticoagulation for 4 weeks. If absent, then directly perform cardioversion without anticoagulant for 3 weeks. This is the CHAT scoring system for the atrial fibrillation, which is used to assess the risk of thromboembolism. For congestive heart failure, there is 1 point. For hypertension, 1 point. For age greater than or equal to 75 years, 2 point. If diabetes mellitus is present, then 1 point. If previous stroke history is present, then 2 points. Vascular diseases is present, then 1 point. Age 65 to 74 years, then 1 point. And if for the sex category, it is 1 point. The maximum score is 9 points. So if the score is 0, then give aspirin only. If the score is 1, then oral anticoagulation is done. If score is greater than or equal to 2, then warfarin is done. So we have started our CVS chapter and we have discussed our first topic, that is atrial fibrillation. First we have discussed the scenario, then what are the causes of atrial fibrillation, then the investigation options, that is ECG, X-ray, echo, TFTs, then the history and physical examination, then what are the symptoms of atrial fibrillation, then what are the signs, then what are the risk factors, then which drugs are used to control the ventricular response, which are calcium channel blocker, beta blocker, digoxin, verapamil, and teletizam. Then what are the management options? There is for hemodynamically unstable patient and the hemodynamically stable patient. Then we are having the CHAT scoring system, then the management according to the score. Now coming towards supraventricular tachycardia. We are having a scenario that there is a 25-year-old female presented to emergency department complaining of palpitations. Her ECG done which shows SVT. She is not having any chest pain, but she was dyspneic on examination. Her pulse is 180 per minute. JVP is not raised and chest is clear. BP was 120 by 80 mm of Hg. So what are the immediate measures that we will do? What medications were given? What to do if BP drops 80 by 40? And what is the permanent treatment to prevent the recurrence of SVT? The definition of SVT is that this is a tachycardia occurring in episodes with rate of 140 to 220 as a result of re-entry or rapidly firing ectopic focus in atria or AV node. It may last from few seconds to many hours. Normally, heart is structurally normal in this condition. Now, the causes are anxiety, smoking, coffee, exertion, alcohol, and hyperthyroidism. The investigation options are ECG, that is 12 leads, which shows tachycardia with normal QRS complex. Then the diagnostic vagal maneuver and the intravenous adenosine. The managements that are done for the SVT is acute episode in hemodynamically unstable patient, then the cardioversion is done. The general measurements are initial vagotonic maneuver, carotid massage, Valsalva maneuver, and lowering head between the knees, pressure on eyes, self-induced vomiting, and breath holding. Okay, then acute episode for hemodynamically unstable patient, cardioversion is done. Acute episode in hemodynamically stable patient, vagal maneuver is done, that is carotid massage and Valsalva maneuver. Then the then the emergent is done which cause vagal stimulation, then vagal maneuvers are done that fall, then drug of choice is intravenous adenosine. If vagal maneuvers doesn't work, then we will give the drug adenosine, that is antiarrhythmic effects. Then if adenosine is not effective, then intravenous beta blockers are given, that is a small one, intravenous calcium channel blocker, that is teletizam and verapamil. For recurrent SVT, catheter ablation is the most effective therapy. Alternative option is prophylaxis with beta blockers and calcium channel blockers. If BP drops into 80 by 40, then perform cardioversion, and the clinical features of SVT are palpitation, fainting, breathlessness, chest pain, and polyuria. Okay, so we have discussed the SVT, the scenario for the SVT, supraventricular tachycardia, then the definition, then the causes, then the investigation options, which are ECG, diagnostic vagal maneuver, and intravenous adenosine. Then there are general managements and the specific management for acute episode in hemodynamically unstable patient and stable patient. Then what is the recurrent SVT and what are the clinical features? Now coming towards stable angina, we are having a scenario that there is a 60 years old male patient, retrosternal chest pain on moderate exertion is present. Pain relief on taking rest. On examination, he is obese, pulse is 84 per minute, BP is 160 by 100 mm of Hg. No nicotine stains of his fingers and some yellow plaques around his eyes are present. Another scenario is that there is a 60-year-old smoker diabetic patient present whose weight is 100 kg. He gets retrosternal chest pain which radiates to the left arm on walking for about 50 uh, years and relieved by taking rest. Episodes occurring from last 1 year, vital signs and resting ECG are normal. Okay, now the stable angina definition, it occurs due to increased myocardial oxygen demand during emotion in a patient of narrow coronary arteries. It is promptly relieved by rest and by nitroglycerin. Then, what is angina? It is a clinical syndrome that is characterized by such sudden chest pain due to transient myocardial ischemia. Now, what are the risk factors? These are increased age, male sex, and family history. These increase the risk of stable angina, and these are non-modifiable risk factors, while the modifiable risk factors are smoking, control of hypertension, obesity, heavy alcoholism, and oral contraception. Now, what are the investigation options? These are ECG, that is resting ECG, best initial test, ST depression, and T wave inversion, normal in patient of stable angina. Then the exercise ECG, that is exercise tolerance test. Then the ECG during pain is done, that is ST segment depression with or without T wave inversion. Then ETT is done, and the isotope scanning, echocardiography, coronary angiography, which is a diagnostic, D vitamin stress test, chest X-ray, and the nuclear test, stress test, and the CT scan, and the cardiac MRI. These are the investigation options for the stable angina. The management options are general and specific. In general, there is smoking is avoided. The aim is ideal body weight, regular exercise, take sublingual nitrates before exertion. The specific are for episode of angina. Nitroglycerin sublingual is given. It relieves pain within the 3 minutes, which includes aspirin and long-acting nitrates. Then for prevention of further attacks, aspirin is given. Beta blocker is used. Nitrates and calcium antagonist are used. The surgical procedures are coronary ABG and stent placement. The complications of stable angina are bleeding, wound infection, atrial fibrillation, renal failure, pre-op MI, and cerebral complication. So we have discussed the stable angina, the scenario for stable angina, then what is stable angina and what is angina, then what are the risk factors of stable angina which are non-modifiable and modifiable, then investigation options which are ECG, CG during pain, ETT, isotope scanning, echocardiography, coronary angiography, D vitamin stress test, chest X-ray, nuclear stress test, CT scan, and cardiac MRI. The management options are general and specific for the episode of angina, for prevention of further attack, and for surgical and complications. Now coming towards the congestive heart failure. We are having a scenario that there is a 30-year-old multiparous female, 30 weeks pregnant, brought to causality with the history of exertional dyspnea and orthopnea. On examination, she is dyspneic, pulse is 112 per minute, irregular low volume BP 100 by 70 mm of H. She is pregnant. She is anemic, edema is positive, on auscultation pain, systolic murmur at apex radiating to the axilla positive. Checks examination revealed bilateral basal capitation. We have another scenario that there is a 25-year-old boy, transfusions dependent, presented to medical OPD with dyspnea, cough, and swelling of feet. On examination, he is pale with grayish pigmentation of the skin. BP is 100 by 70 mm of Hg. JVP is raised with bilateral pitting edema, and examination shows hepatosplenomegaly. So, what is the diagnosis? What complications has she developed? What is the valvular lesion? What is the investigation, management, the cardiac complications, and the complications of repeated transfusion? So, here we are having the repeated transfusion history. So, the case is congestive heart failure. The definition of congestive heart failure is that it is a condition in which heart is unable to pump blood at a rate required to meet the metabolic demands of body, tissues, and organs. The clinical features of congestive heart failure for left heart failure and right side failure are: for left heart failure, it is the most common. It is called forward failure because left side of the heart can eject blood into the aorta. Pulmonary congestion or edema occur, dyspnea occur, that is cardiac asthma, then orthopnea, the dyspnea or lying flat, then PND, the SS heart sound, then basilar inspiratory cackles on chest auscultation, and pain systolic murmur because of the mitral wall regurgitation is present. On right side, it is called backward failure because right side of the heart can pump blood from venous system to lungs and blood accumulate in venous system. Increased JVP, that is right side S3 and S4 sound. Tricuspid regurgitation is present. Painful hepatomegaly is present. Ascites, edema, pitting pedal and peritibial edema, which is the hallmark of right side heart failure and general edema. Now the investigation options are blood test, that is CBC for anemia. UEC, that is urea, creatinine and electrolytes for renal failure. Then TFTs, that is hypothyroidism and hyperthyroidism. Cardiac enzymes are done for acute heart failure. Brain natriuretic peptide is done. Chest X-ray is done for cardiomegaly and pulmonary edema. ECG is done for ischemia, left ventricular hypertrophy, previous MI, heart block and arrhythmia. Echocardiography is the most accurate test which distinguishes the systolic response from diastolic dysfunction, and the determination of ejection fraction is done. Transthoracic echocardiography is done, which is heart wall function and diameter. Nuclear ventriculography is done, and multiple gated equistation scan is done. The treatment options for congestive cardiac failure are we are having the non-pharmacological treatment and the pharmacological treatment. In non-pharmacological treatment, cardiac resynchronization therapy is done, implantable cardiac defibrillations are done, ventricular assist device is done, and cardiac transplantation is done. In pharmacological treatment, loop diuretics are given, ACEs and ARBs are given, beta blockers avoided in developmental decompensated congestive heart failure and should be started once patient is euvolumic, and causal treatment is done. Okay, now management for systolic dysfunction and diastolic dysfunction. For systolic dysfunction, ACE inhibitors, ARBs, beta blockers, spironolactone, hydralazine plus nitrates, implantable defibrillations, and zoxine are used. For diastolic dysfunction, beta blockers and diuretics are used. The advanced treatment is biventricular pacemaker and left ventricular assisted device. The lifestyle modification is important for congestive heart failure, which is quit smoking, weight reduction, low sodium diet, and exercise. The complications are kidney damage, kidney failure, liver damage, and MI stroke. So we have discussed the congestive cardiac failure, that is overloaded or crowded heart. Then we discussed the scenario that there is a 30-year-old multiparous female which is 30 weeks pregnant and brought to casualty with a history of exertional dyspnea and orthopnea. On examination, she is dyspneic, pulse is 112 per minute and is irregular, low volume BP 100/70. She is anemic, edema positive, and on auscultation, pensystolic murmur at apex radiating to the axilla positive, and chest examination revealed bilateral basal crepitation. So, what is the definition of the congestive heart failure? Then, what is the left heart failure and the right-sided heart failure? Then, what are the investigation options? These are blood test and the urea, creatinine, electrolytes, and the TFTs. Then the cardiac enzymes, the brain natriuretic peptide, the chest X-ray, ECG, echocardiography. Then the transthoracic echocardiography, the nuclear ventriculography, and the multiple gated equistation scan. The treatment options are non-pharmacological treatment and pharmacological treatment. The management options are for systolic dysfunction and for diastolic dysfunction, and the advanced treatment, then the lifestyle modification, and then the complication. Now coming towards myocardial infarction, that is MI. So we are having a scenario that there is a 50 years old man developed acute and anterior chest while sitting which lasted for 3 hours till he arrived in casualty. On examination, breathlessness, sweating profusely. He is smoker for 10 years and hypertensive for 5 years. Overweight, BP is 160/105 mm of Hg. Muffled heart sound and basal capitations over lungs are present. We have another scenario that there is a 50-year-old patient having severe anterior chest pain radiating to left jaw for past 1 hour. He is smoker and works in bakery. On examination, he is sweaty and overweight. His BP is 160/110 mm of Hg and muffled heart sounds and bilateral basal capitations over the bases of the lungs. What is the definition of MI? Myocardial infarction is ischemic necrosis of the area of myocardium, or it is a myocardial necrosis occurring as a result of critical imbalance between coronary blood supply and myocardial demand. Now we are having okay, let's discuss first pain, that is retrosternal and radiating to jaw and left arm. These are the diagnostic points, and it is acute in anterior chest and muffled heart sounds are present, and there is no response to sublingual nitrates, and the duration is greater than 30 minutes, and profuse sweating and breathlessness is present, and basal capitations are present. So what is the diagnosis, investigation, and complication treatment? Okay, Now we are having two types of MI, that is non-STEMI and STEMI. An NSTEMI is localized area of the myocardial necrosis and having elevated cardiac enzyme. ECG shows ST depression plus minus TFF inversion. Okay. In STEMI, localized area of the myocardial necrosis, elevated cardiac enzymes are present. ECG shows any of the ST segments elevation of greater than or equal to 1 mm or greater than or equal to 2 mm or new left bundle branch block. Now, the clinical features are chest pain radiating to the jaw, neck, and arms, breathlessness, vomiting, collapse severe and longer than angina, tightness, heaviness, and constriction in chest. The investigations that are done for the MIR ECG, that is ST segment elevation and T-wave inversion, are the signs of MI. Series ECGs are more appropriate. Then cardiac enzymes are done. Troponin T and I are highly specific and are raised in 2 to 4 hours. Then echocardiography is done, which confirms the diagnosis. Angiography is done to find the vessels involved. The others are serum myoglobin, AST, blood CP or ESR, X-ray chest, and radionuclide scan. The treatment options for MI are general measures, specific or immediate measures, and long-term management. In the general measures, first of all, bed rest is done, and the clear liquids for 4 to 12 hours is used. Laxatives if constipation is present, and sedations for anxiety. And if oxygen, if decreased, then saturation is corrected. For specific or immediate management, we will give the sublingual nitrates. If no hypertension is present, then analgesics for pain relief, that is morphines. O2 inhalation is done. Antithrombolytics, antiplatelets, and anticoagulants are given, that is streptokinase, aspirin or clopidogrel, and low molecular weight heparin. Percutaneous coronary intervention, coronary artery bypass grafting. For long-term management, lifestyle modification is done. Medications are given, which are aspirin and clopidogrel, beta blockers, nitrates, statins, ACE inhibitors, and in advanced case, implantable and cardiac defibrillators are used. Okay, so we have discussed the MI, the scenario for MI, then the definition, then the difference between NSTEMI and STEMI MI, the clinical features, then the investigations that are done, which are ECG, cardiac enzymes, echocardiography, angiography, and the others, then the treatment options, which include the general measures, specific measures, and the long-term management. Now, coming towards the rheumatic fever, we are having a scenario that there is a 16-year-old was brought by her father with painful and swollen right ankle and left wrist joint after getting better from painful left knee joints. She is also giving history of breathlessness and palpitations. On examination, she is febrile, pulse is 110 per minute, and above mentioned joints are swollen and tender to touch. Cardiac examinations reveal systolic murmur radiating to the axilla. So, what is the diagnosis? Then justify your answer. What are the valvular regions present? Enumerate skin manifestations of the disease and what are the treatment options. So, the definition of rheumatic fever is that it is a systemic inflammatory disease triggered by pharyngitis with group A, B hemolytic streptococci, and it is the most common cause of acquired heart disease in childhood and adolescence. The diagnostic criteria for rheumatic fever is 5 major and 4 minor points are present, and the evidence of recent infection is present. The positive culture of the infection plus 2 major criteria diagnose the case of rheumatic fever, and increase SO titer plus 1 major or 2 minor criteria diagnose the case of the rheumatic fever. In major criteria, we are having the migratory polyarthritis, carditis, subcutaneous nodules, erythema marginatum, that is skin rash, and sudden harm chorea is present. In minor factors, we are having elevated ESR, increased CRP, fever, prolonged PR interval, leukocytosis, and arthralgia. The clinical features of rheumatic fever are migratory polyarthritis, painful asymmetric joint, and carditis. Then the skin manifestations are that subcutaneous nodules are present on external surface of the joint and spines. Then erythema marginatum is present and sudden harm chorea is present. The investigations for rheumatic fever are CBC, that is leukocytosis. Then raised ESR and C-reactive protein is done, which is useful for the monitoring of progression of the disease. Then evidence of the streptococcal infection is done. Then the throat swab is checked, and then anti-streptolysin O antibodies is done. Chest X-ray is done for cardiomegaly and pulmonary congestion. ECG is done for first degree IV block, and echocardiography is done for cardiac dilatation and valve abnormalities. The treatment options for rheumatic fever are bed rest, that is bed rest, close monitoring, and stall restriction if signs of congestive cardiac failure is present. Eradication of infections, that is drug of choice is benzyl penicillin, penicillin G, and intramuscular injection of benzathine penicillin 6 to 12 lakhs units, or oral penicillin G 500 to 1000 mg 4 times per day, or amoxicillin is given. Patients who are allergic to penicillin should be treated with azithromycin, erythromycin, clindamycin for 10 days. Anti-inflammatory drugs are given which are primary and secondary. In primary, appropriate antibiotics therapy started before 9 days of symptoms of acute pharyngitis is effective to prevent the first attack of acute rheumatic fever. For secondary, any one of the drug is used, that is benzathine penicillin intramuscular 6 to 12 like units every day for 4 weeks, or penicillin V, that is 250 mg oral twice per day, or erythromycin in case of penicillin allergy 250 mg per day. The duration and the rheumatic fever without carditis 5 years until age 21, whichever is longer. If the rheumatic fever with carditis but no result heart disease, then 10 years or until 21 years of age, whichever is longer, no valvular disease. Rheumatic fever with carditis and result heart disease, then persistent valvular disease, lifetime prophylaxis may be needed. Some cardiologists recommend discontinuation of prophylaxis after the age of 40 years, since likelihood of the reduced recurrence beyond this age is minimal. Okay, so we have discussed the case of the rheumatic fever, the scenario for the rheumatic fever, then the definition, then what is the diagnostic criteria. We are having the 5 major and 4 minor criteria, and the evidence of the infection. Then the positive culture and the 2 major criteria, or increases or titer plus 1 major and 2 minor criteria confirm the diagnosis of the rheumatic fever. Then we discuss the major and minor criteria and what are the clinical features and the skin manifestations in rheumatic fever. Then we discuss the investigation options, which are CBC, raised ESR, and C-reactive protein, evidence of the streptococcal infection, throat swab, anti-streptolysin O antibodies, then chest X-ray and ECG and echocardiography. Then we discuss the treatment options, which are bed rest, eradication of the GABHS, then anti-inflammatory drugs, which are primary and secondary, then the duration, then rheumatic fever without carditis and the rheumatic fever with carditis, and the rheumatic fever with carditis and residual heart diseases. Okay, in the next part of our video, we will discuss the mitral stenosis. Okay, we will cover this unit of CVS in 2 videos. In the first video, we have covered the following topics, that is atrial fibrillation, supraventricular tachycardia, stable angina, congestive cardiac failure, myocardial infarction, and rheumatic fever. These topics are already discussed. In the next part of this unit, we will discuss in next video mitral stenosis, aortic regurg, infective endocarditis, hypertrophic obstructive cardiomyopathy, and pericarditis, and constrictive pericarditis, cor pulmonar, and DVT, that is deep venous thrombosis. Thanks for watching.